Hello, my name is Fidelis Ezewike, a P3 intern studying at Florida A&M University from Miami Lakes, Florida. The EBM journal that I chose was a very interesting topic to me, entitled Lexicentide in patients with type 2 diabetes and acute coronary syndrome. So I'll basically be giving an overview, a summary of how the research was conducted, on what it entailed and the results. So first of all, the background information. Type 2 diabetes are noted with increased likelihood of experiencing cardiovascular morbidity and mortality. In this study, type 2 diabetics who had a recent acute coronary event were given lexicentide in efforts to assess its effects on cardiovascular outcomes. This is a great study because it's noted around the RX land, the pharmacy community, that the type 2 diabetic off rip has more chances of hypertension, heart failure, just resistant problems with the heart, things that's stroke, hospitals on more hospitalizations than the average person. So, in this study, we're just trying to say, okay, if we give lexicentide, which is a GLP agonist, what's going to happen? Will it benefit? Will it be worse? Or will it have no effect to the cardiovascular health of the patient? So the way we did it is it was two arms, the lexicentide pill or the lexicentide treatment, and then a placebo treatment. The trial design was very, very well conducted. It was multiple centers, many places, but the study focused on Boston because that's where the study originated, but it was many places. It was randomized, to negate the biases, double blinded. So the patients didn't know what was going on. The doctors didn't know. It was only like the pharmacists that were preparing the study that understood the process. It was placebo controlled, and it mandated that we choose a type 2 diabetic, of course, but they must have had a recent acute coronary syndrome or acute coronary event within 180 days. That was an inclusion factor. Exclusion factors where, things are, if they're not a diabetic, first of all, if they were under the age of 30, if they were a pregnant woman, if their kidney couldn't even take the drug lexicentide, so, to prevent damage. Exclusion factors were things like that. So the primary endpoint, what we're trying to see time to event analysis of when the first occurrence of any of the following would happen. Things like death from cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke, hospitalization for unstable angina. So, we were trying to see these things and compare the lexicentide, of course, with the placebo, and that would tell us at the end of the study, what is there really a difference? Is the power big enough that we can say it's clinically significant? That's what we're trying to see. The study lasted for 712 days for the placebo group and 690 days for the lexicentide group. It had a decent amount of people, which is what I like about the study. Once again, it was from multiple places, multiple locations, actually 49 countries, which is very good. And in those 49 countries, we encompassed 6,068 patients. Half on the lexicentide, half on the placebo. So when it comes to the goals, the primary endpoints, this is the data that was returned. 406 patients had a non-fatal or fatal myocardial infarction in the lixisenatide group. Meanwhile, 399 patients had a non-fatal or fatal myocardial infarction in the placebo group. The range was not too big on that one. The power was not too big on that one. A total of 67 patients on the lixisenatide group and 60 patients in the placebo group had a fatal or non-fatal stroke. Once again, the difference is only 7. And a total of 11 patients in the lixisenatide group and 10 in the placebo group were hospitalized for unstable angina. Once again, that was only a 1 patient difference out of all of those patients we had or they had in the study. So, that shows you, even before I get to it, that the difference was not too profound. It already seems as if the lixisenatide is not clinically significant or proven that to reduce any mortality or morbidity of cardiovascular events. So the adverse events that we noticed in the study were basically GI events, really just GI events like nausea and vomiting, things that'll go away in time, or if that person has a significant problem with that, then maybe it'll last longer and we have to give them some type of drug to offset that. But other than that, everything was really good. So the author's conclusion was that in patients with type 2 diabetes and a recent acute coronary syndrome, the addition of lixisenatide to usual care did not really significantly alter the rate of major cardiovascular events or other serious adverse effects. So basically, if I'm in the pharmacy right now and a patient comes to me and I know that they're prone to these type of events, I'm not giving them lixisenatide. Like, I'm not seeing that as clinically significant enough for me to prescribe that for them. So as I critique this journal or this article, it has some strengths. The strengths was the sample size and how random the patients were chosen. Because once again, it was 49 countries. And in those 49 countries, 6,068 people. The sample size was very well. It was a very well controlled study. So if there was a major difference, it would be able to be shown. But since there wasn't a major difference, it was also able to be shown, which is